So we're continuing with the CMS program on the 12 steps towards QAPI. And so we're marching along here. Just as a background information, the month, or the theme for this month, is social isolation. So we're doing quality improvement around patient-centered care as it relates to social isolation. And so we're looking for opportunities to create a PIP around social isolation. It doesn't have to be a big one. You know, the intervention can be very small and tested is all we're really looking for. And then by electoral college voting, we all voted for fall reduction as our next theme. So as we move into the June sessions here, we'll be doing falls. And I actually got a model PIP, Plan, Do, Study, Act cycle on falls from one of the geriatric programs that applied this in a nursing home in one of the VA facilities. So I see Norma's on, so from the veterans home here in North Dakota. So I'll get you those slide decks for sure, because it is focused on the VA, but definitely demonstrated the overall process, as to how they reduced falls. So that was good. All righty. The other thing that I wanted to mention, just as part of an announcement, is that we being University of North Dakota, are looking for continued support of these what we call ECHO. The ECHO stands for Education for Community Health Organizations. It has an easy name to remember, ECHO. And so we wanted an extension from the federal funding agency, HRSA, to provide this type of what we call telementoring. But what we'd like to do is get feedback from everybody, of all our participants, as to what topics come to mind, what problems that you have. And if you can give us some feedback, we're actually going to design the curriculum. And it's a regional curriculum. It's meant to be delivered in what I call the Great Plains Mountain region. So it would involve a lot of rural, focused things, because we're collaborating with University of Utah, Wyoming, and Montana, in addition to Dakota and South Dakota. So it's a regional program where we're trying to pull in a lot of expertise, from people that are familiar with things like resiliency, engagement, leadership, and all those that can be opportunities for our consortium to learn and move forward, and build on the quality outcomes for long-term care, as well, so for both nursing home and also for congregate housing. So we're going to include assisted living in that effort. So anyways, just that's what we're marching towards here. And if you have some specific ideas, please email us about that, and that'd be really helpful, because I'm applying for the grant now and I need your feedback. We did the survey, and so we got some ideas, but if you have some specific topics that you want to cover, or some specific problems that you feel that have not yet been addressed, please let me know, because I'll put it in the grant and we'll get it we'll get it front and forward there. Okay, so let's go ahead and move on here. We were just wondering, again, anything that came from walk rounds. So if you want to put in the chat box any revelations, observations that you had from your walk rounds. You can also unmute yourself if you want to mention something that you got from walk rounds in the last week or so.
Dr. Jurovich, I'll give a quick example of one of the facilities that I'm working with is during they were working on a hand hygiene tip, and they were able to identify one consistent step that was missed by all of their staff, and it was on when you're turning the water off. They were using the same paper towel they dried their hands with, and they were consistently missing that step. So they were able to go back to their training materials and see that that wasn't identified. So those observations and audits are really helpful to determine what the root cause of failing to comply with the policies. So.
Yeah, so that's a very good point. Where through observation, and again, the observation doesn't have to be leadership, right? It can be somebody that you assign. And then I've mentioned previously that I used to deputize housekeeping, and there were the eyes and ears, and so there was a little bit of a what I would say a Fortnite battle, for those that play video games, between housekeeping and nursing, which was kind of unfortunate. We didn't intend it to be that way. So sometimes you just have to, let folks know that we're all doing this together. But anyways, they identified some gaps in just whether anybody was applying hand hygiene, going from room to room. So good. Okay, and then the other question is does anybody have any concerns about the PIP for social isolation? And this is probably more directed towards the people that have not yet created a PIP. And it'd be just important to identify barriers. Is time a barrier? Is insufficient staff a barrier for creating a PIP on social isolation or other things? So I think we have out of the 20 plus facilities that are on this consortium here, I think we got about a half dozen PIPs that were delivered. Is that, Casey, are you on the session here? Is that about right?
Yeah, that's about right.
Gotcha. So anyways, I'm assuming that the other 15 or so facilities have not gotten around to submitting their PIP on social isolation. So we're just looking for feedback on that as to, again, what the barriers are. We were talking to one facility here recently, and they said that their census is lower, and so you'd say, oh, so that means more time, for doing PIPs, and they go, well, not so quick. He says, because the staff aren't there either. So, it's always a mixture of, issues that are going on. But again, we want to emphasize the idea that the quality improvement gets integrated and ingrained in each and every individual working in the nursing home, as well as potentially volunteers that might work with the nursing home, and also family members. So as a point of reference, this curriculum that we're extending or expanding upon that I mentioned earlier, one of the things that I'd dearly like to do is provide training for family members to engage in quality improvement. So the idea is, what would their involvement look like, and how can they be a source? And quite honestly, I think the patient-centered care element, for them would be very important. So a lot of times family members sort of pick up they foster another resident, so they may visit somebody else, and that may be important for what I call the lone ranger, the individual that doesn't have family members, or has family members but they don't show up all that often, if at all. So again, using that volunteer workforce can really help alleviate that. The other thing, by the way, in terms of ideas, has been trying to connect with college students, medical students. There were a lot of presentations here recently in our geriatric meetings about medical students interacting with nursing home residents through either televisits or telephone calls or letter writing. And so that's another avenue for making those connections. So we can discuss that. And, you know, as a, you know, a resource at University of North Dakota, you know, we can convey those interests, you know, so if you guys have an interest in engaging student trainees, just let us know, and, you know, we can try to, like I say, get the glue to bring things together. So,
Jay, I'd just like to make a suggestion or a comment about, you know, time management. When we look at time constraints to incorporate quality improvement in your daily routine, if you don't have a standardized agenda for your morning meeting, then, or your daily meeting that you have with your leadership team, maybe you would consider that. A lot of times that can save you probably 15 to 20 minutes. I've been in lots of morning meetings that tend to get off track and take a little longer. And then you can really utilize that 15 or 20 minutes to work on some of, maybe one of your PIPs, or have your team go out and do the observations that are needed, or whatever. You can save that 20 minutes. But a standardized agenda for those meetings really keeps it on track and can save you some time and utilize that time for something else.
yeah, and the other point in terms of efficiency, our intention is to create PIPs that are kind of, you know, ready-made, kind of like, you know, when you get a meal in a box and, you know, all you have to do is just put it in the microwave or whatever. We want to get PIPs that are ready-made, and you just have to fill in your own, you know, facility-specific issues. You know, so expand, because a lot of these things are thematically in common. So, for example, when people did the survey on social isolation, you know, and finding anywhere from 37 to up to 47, 50% of residents were screening positive for social isolation. Yeah, I mean, that's common information that you can use, right? I mean, you can use the surveys, you know, that other people have done and shared those as a basis for conducting the PIP. And I don't know if we've been able to distribute that to everybody, right, Casey? We have not gotten permission yet to distribute the PIPs and share them with our group.
Not to my knowledge.
Yeah. So that's really the next step, you know, is that we want to have a archive of PIPs that people have created, and then with permission, share those with the consortium so that people can, like, you know, pick one. I mean, I think what we'll do is just have one that we think is a model example, and then distribute that. We can even make it in a generic form, quite honestly. So, all right, can we move on to the next slide here? So today we want to continue with the Institute for Healthcare Improvement curriculum. Again, based upon our survey and poll from all of you, we're going to continue to focus on the emotional and organizational support for staff and well-being. And then we're going to move into the foundations, you know, for step 10, about actually going through the process of planning, conducting, and documenting. Importantly, documenting. That's kind of why we're doing the homework. So if you can document what you're doing, it's on the books, folks, you know, so we can, you know, it's there. And we can hopefully, you know, tweak that along here. So you have that in your PIP directory yourself. And then we're going to talk about the next steps for the Plan, Do, Study, Act cycle here. Okay, so let's, can we move in then to the, we have the video? Yep.
Hi there, my name is Paige Hector, and along with Angela Devaney, I'm excited to bring this module, Emotional and Organization Support, to you as part of the continuing phase of the Project ECHO. And in this session, Angela and I will cover these objectives. I'll be talking a lot about trauma-informed care, emphasizing safety and trust, perceptions, triggers, and re-traumatization. Angela will talk about what matters to you, the framework, as it relates to staff well-being, and she'll bring us lots of improvement tools. So this module is comprised of 5 weeks of material, and we do strongly recommend that you follow the sessions in this designated order. Before we dive into the content for today, I want to take a moment and just see how everyone's doing. What is top of mind for you? What has come up from last week? Has there been anything particularly challenging or frustrating that you would like some help with? Don't hesitate to reach out to your training centers, as we are all here to help support all of the nursing homes across the country. In order to make our time together as interactive as possible, every week we'll start off with a discussion question based on a weekly topic. So for this week, what does well-being mean to you? Angela and I spent a lot of time talking about well-being and what it means and how we would know where to take this material. A very timely report from the Kaiser Family Foundation came out, and I really felt that it was sobering and wanted to share some of this material with you. Healthcare workers are experiencing stress across many areas, from trouble sleeping and headaches, increased substance use, and feelings of being burnt out, anxious, and even angry. About 1 in 10 have received mental health services, but yet another 2 out of 10, and I personally think it's more than that, would like to receive mental health care, but for whatever reason are not. You know, sadly, mental health care is stigmatized in our greater society and culture, and it's time to change that. Our well-being on it, as does our ability to care for the residents in our nursing homes. So what's the connection between culture and trauma-informed care? There's lots of definitions of culture, and we could go on for days about that, but simply put, culture is the way that we do things around here. How people are greeted, how we run our meetings, and how information is shared. And as part of that culture, and every aspect of the culture needs to be infused trauma-informed care principles. What I want to share with you is that trauma-informed care is not a destination. It's not somewhere that we get to and say, aha, we've accomplished it, good job. It's actually an ongoing fluid journey. And the good news is that you are likely engaged in some trauma-informed care principles already in your facility. The definition of emotional and psychological trauma is the result of extraordinarily stressful events. I mean, you could stop right there and say, yep, the pandemic, right? Basically, your sense of security is shattering. You might feel helpless in what we might perceive as a dangerous world. There could be a threat to life or safety, but any situation that leaves you overwhelmed and isolated can result in a trauma, even if there's no physical harm. When I talk to people about trauma, a lot of times they say things like natural disasters and murder and accidents. Those sorts of things come to mind. And of course, those are certainly more than likely traumatic events. But I want to point out that trauma can be an individual event, a series of events, or a set of circumstances like the pandemic. And what's unique about this is that it doesn't just affect us at work, it's across all parts of our lives, at work and at home and everywhere in between. But what I want to share too is that just because we have this shared experience of this traumatic event of a pandemic, set of circumstances, it doesn't automatically mean we will all be traumatized. Trauma is an injury. Trauma is not a weakness. It is not an illness. It's not a character flaw. And I'd like to get us to shift from, this is one of the key principles of trauma-informed care, shifting from a mindset of what's wrong with you or another person to what happened to you, and that we approach situations with curiosity and wonder and a desire to seek understanding of another person's experience. Dr. Bessel van der Kolk is a preeminent researcher in the world of trauma work, and he talks about the virus being a pre-traumatic condition based on 2 core variables. Number 1, immobilization. I mean, that's pretty clear, right? Whether wherever your state is at in terms of being open and visitation or no visitation, we've all experienced some degree of immobilization. Unpredictability, that's everybody. We have not known what's going to happen day to day or even moment to moment in some of the more crisis-driven times of this pandemic. And what Dr. van der Kolk would say is that when the world is unpredictable and we cannot move around freely, the vulnerability to becoming traumatized is very great. There are 6 principles of trauma-informed care, and each of these needs to be woven throughout all aspects of your culture and your nursing home. We're going to focus on the first 2 of safety and trust. So what does safety mean to you? How would you define it? What would it sound like or look like or feel like? And how might your colleagues or coworkers think about it? What would your residents say? Their family members? How would they describe a safe environment? So a safe work environment includes several things, from the physical plant, right, that your facility itself, the building, is a safe place in which to work. You have security. There's disaster planning and policies and procedures to keep you safe. But safety within a trauma-informed framework actually exceeds all of those standards and expectations to include emotional safety. In other words, things like, do people feel empowered to speak up? Do they have a voice? Can they discuss challenges, or can they disagree with one another in a respectful way? There has to be zero tolerance for blaming, bullying, and retaliation. And additionally, a trauma-informed care culture in the realm of safety actually has an element of being able to process distressing circumstances. I want to make it clear here that that does not mean that we become each other's therapists. That is not what we're talking about. What we are talking about is expanding our ability to talk about trauma and trauma-informed care in a way that is inclusive, and it helps us to feel more safe and more trusting of the environment in which we work. A colleague of mine, Dr. Bickle, out of the University of Colorado, she talks about residents, and she would ask the question, you know, do residents feel unsafe in your nursing home? And I'm asking the same question about staff, because there's no doubt that all of you on this call want to create an environment that feels safe. And our instinct is, well, of course we do this. Of course I already do this, because we cannot imagine, you know, coming to work with the intention to hurt or traumatize people. I'm a caring, compassionate person. Of course I don't traumatize people, you might think. And the reality, everyone, is that we can trigger, we can inadvertently re-traumatize people. And that's why bringing more awareness around this and bringing it into our nursing home culture is so important. So just like safety, you know, what does trust mean to you, to the residents where they live there at your nursing home, and the residents and staff? You know, the qualities of trust include respect and compassion and a genuine desire to be present with and to relieve other people's suffering. That there's predictability with processes and daily activities that help build trust. That we make a conscious effort to not re-traumatize people. But the really important part here is that we don't have to get it right all the time. I want to take that pressure away, because we will make mistakes. We will traumatize people. The environment in which we work will trigger people. That's okay. It's how we recover from those that's really important. Our perceptions of safety and trust are crucial. And while we might have some things that we agree on, there could be things that we disagree on as well, and that's perfectly fine. So a perception is simply our version of the truth. It doesn't necessarily mean good or bad or right or wrong. It simply is. So if we can seek to understand what you, what I, what everyone else thinks in our nursing home is a safe culture, and then how to contribute to that, that's what really becomes what becoming trauma-informed care culture is all about. So in addition to the 6 principles, there are 4 concepts of trauma-informed care. We sometimes call these the 4 R's. We realize the widespread impact of trauma, which I think we are just beginning to understand this in terms of the pandemic, how far-reaching the implications are. Recognizing signs and symptoms of trauma, not just in our residents, but in all of us as staff. Responding about how we integrate trauma-informed care into our policies and procedures and daily practices, and that we actively resist re-traumatizing people. Let's delve a little bit deeper about those two topics there. So a trigger is anything at all. It can be a smell, a sound, a sight, an emotional feeling, something inside of you, or a situation you find yourself in. Anything can be a trigger, and that might feel a little bit overwhelming because we don't know all the different ways that our residents and each other, and sometimes even ourselves, might be triggered at any given moment. If we can approach with curiosity and that wonderment of of what happened, not what's wrong with you. I think we can do better at finding out what these triggers are to avoid, like that second point there of re-traumatization. Basically things that happen in our environment that literally take us from the moment here and now to the then and there, to the event, the traumatic event that happened, or a part of that event that happened, the original experience. That's what we're seeking to avoid here. So when I was thinking about all the different things that might be triggering in terms of the pandemic, here's a few that I came up with. So from a multisensory perspective, our senses, sight, sound, smell, touch, and taste, the sound of sirens, the crinkle of gowns, the smell of gloves or putting gloves on, seeing our residents sitting alone in their rooms or calling out for help, shortness of breath. Maybe some of you have felt that sensation of feeling claustrophobic and all of the PPE or the frustration of it. Feelings of fear and powerlessness and uncertainty and isolation and exhaustion, all of those emotional states can actually be triggers. Situations, being refrained from touching. Can you imagine for over a year we've not freely been able to touch or hug or hold? And touch is such a basic human element, especially in our nursing homes. I'm wondering now, as we shift to a time that we hopefully soon will be able to touch and to hug one another, if that actually might be triggering. I'm curious how that's going to play out. Being around people in crowds and residents dying alone, all of those situations can bring about a sensation of being triggered and taking us right back to what that event reminds us of, the original trauma experience. So triggers are important for us to try to figure out what they are, because they can be interpreted as really one of three things. I'm not safe, I can't protect myself, or I am going to die. And remember the connection with perceptions, that when we have a trigger, that is our perception of the way our body, our mind, our biology is interpreting that event, whether it's a feeling or a sensation inside of us or something in the environment, that is our interpretation. So what do we do about that? Approach with a universal precautions model, a framework. You know, infection control is something all of us are really familiar with, right? We glove and we gown and we assume that everyone has an infection. That's how we help to keep ourselves and each other safe. So metaphorically, I want you to envision trauma-informed care and gloving and gowning, the idea that assuming that all of us come to this with some level or degree of traumatization. So we put our gloves and gowns on metaphorically. We adopt the presence of listening and seeking to understand and asking the question, what happened to you, rather than what is wrong with you? So thanks for sharing your time with me. I look forward to next week's topic of emotional intelligence as it relates to our stress response. See you next week.
Great. So just open it up to any comments or questions. You're more than welcome to put your comments in the chat box if you wish. And just reflecting on any special interventions that anybody has done for either staff or residents. I think one of the things that we talked about was as there's congregate dining occurring now, that the potential of having thematic lunches or dinners, a fiesta, or other celebrating other ethnic foods and events. I guess apparently it was Norwegian Independence Day here recently. I don't know if one of my faculty mentioned that she got a little box from the Norwegian Center. She said it was the most amazing box of little chocolates. So small things can really make a big difference. And I know that there was a news report about a young lady, grade school girl, elementary school, who went around surveying residents and asked them what they would wish for. And some of them came up with Jimmy Dean's sausage, and others came up with a chocolate cake. Of course, probably that was the resident that had probably was on 50 units of insulin. But, this young lady basically was able to provide, you know, those small tokens, gestures of gifts, you know, for the residents. So just having kind of a make a wish program seems to have some traction here. All right, so I guess we have most folks are kind of kicked back here and listening in the listening mode. So we'll progress to the next part here. So Kelly and Jean, do you want to take it away on our QAPI?
Absolutely. And everybody bear with me a little bit. I'm covering for Michelle today. So if I slip on my words, apologies. But this week we are going to dive a little bit deeper into step 10. We finally made it. So 10 out of 12 steps, we're getting there. And it's on planning, conducting, and documenting PIPs. Now, I realize that we have been working on a PIP since the beginning of this series. So we're kind of already in depth with the PIPs right now, but we really just wanted to do a refresher on this step and go through it in a little more detail. So this is, once again, a step 10 from the QAPI at a Glance program. And before we go to the next slide, I've jotted down a note and I just forgot to mention it. In the very beginning, we talked about how our next PIP is going to be on fall reduction. And what I've noticed with a lot of the facilities that I've been working with is we've been so hyper-focused on infection prevention processes that we have not, some of the other quality of care aspects may not have got as much attention and they may have increased. So we may have an increase in wounds or an increase in falls because there's been a hyper-focus on the infection control side of it. So it's a great opportunity to take a look at some of those other systems now that we're kind of getting through the pandemic the best that we can. Okay, you can go ahead and go to the next slide. So broadly, we encourage PIPs to follow the model for improvement that was put out by IHI. This model, one of the reasons that I like it the most is you can share this with really all levels of staff because it's quick and to the point if you just look at the image here. And first you want to look at what are you trying to accomplish before you put a PIP in place. And you can get that from any kind of data and measurement. So if you're looking at quality measures, or do you look at a repeat deficient practice? When you're rounding, did you identify that there's something that's off every time? Or as I mentioned in my example earlier, the facility that was working on hand hygiene noticed that one piece of that hand hygiene that folks were non-compliant with. So what are you trying to accomplish and what is your aim? Next, how are you going to know that the change is an improvement? Now, really relate this back to your SMART goal. We talked about SMART goals in the last phase and how you can be specific about it and make it measurable and such. And so if you see that you want to do this by this time, you want to decrease falls by 10% by the third quarter of the year, then you'll know if you have an improvement, right? And then last but not least, what can we what change can we make that will result in improvement? And this is really focusing on your interventions. So what steps can be put in place in order to make that improvement? Once you identify those steps or those interventions you want to put in place, that's when we really want to test the change and go through that PDSA cycle. And these are all tools that we have introduced before. We just really are refreshing on them. You can go ahead and go to the slide. Perfect. So this is just really a detailed explanation of your Plan, Do, Study, Act cycle. IHI does have these tools available on their website, and the links are listed here. So first, we're going to plan. We want to know what opportunities for improvement are out there. Let's analyze data and identify those concerns, and make sure that we have residents that are identified, what kind of data we're going to compile, and what solutions you may want to test. And then do it. Run your small tests on a small scale. When we were talking about earlier time constraints, if you need to spread that out a little more, say, hey, we're going to make sure on Mondays every week we're doing a test of something and then collect that data, opposed to trying to do it all in 1 week and do it over a 4-week period. So just kind of look at how you want to test that, but make sure that you're documenting it. For instance, we talked in the last series, we did the PIP on the screening process. And something that was identified during that testing period is that the screening forms that were used were not accessible to the vendors. I think is one of the areas that we came up with that was an issue during that due process. Then study those results. So it may be that we need to reevaluate that form that you're using for screening, like we had discussed last series, and then summarize, reflect, and then determine what you want to do then. Do we need to adapt something? Do we need to adopt it and implementing it in other systems or programs? Or do we just need to completely abandon it, go back to step one? And there are instances that occurs, but for the most part, you'll be able to learn some areas that were not working appropriately, and then you can adjust, or adapt the test of change and then go through the cycle again. Ideally, you would love to be able to adopt it and then just move forward and not have to go through that process again. But we have to remember, in order to get to the improvement side, we have to get to that root cause and make sure that we've corrected that root cause. Go to the next slide. Perfect. So this is something that we looked at last week briefly, and we highlighted this change package in one section of it last week. Well, this is just examples here of how to implement those tests of change. Here it tells you specifically you can use that PDSA cycle, and there's lots of great ideas for your facility to utilize in here. I think these tools are helpful, so you're not starting at the very bottom. You really have an opportunity to look at what other facilities have done or have put together and see how you can incorporate those into your facility practice. So I really encourage you all to take a look at this. And if I'm remembering correctly, Michelle had mentioned last week that this is based on multiple facilities and their best practices, and they were the ones that helped put this together. This change package. And last but not least, some more educational opportunities from the Quality Health Institute, IHI. And these trainings here, the reason that I think they're so beneficial is that you can really utilize them for all levels of staff within your facility. So if you need something for QAPI training for your CNAs or for your housekeepers, because ideally we want everyone to be involved in that process. Some of these are very short scripts that really give a quick at-a-glance picture to them and how they can participate in the QAPI or the quality improvement within your organization. And I am going to pass to, if there's no questions, I'm going to pass to Jean, and Jean is going to share one of our, the PDSA cycle from Ava Maria.
All right. Well, you know, sometimes I think it can be very difficult to find just the right tool to augment work and quality improvement, you know, and to find a tool that's just right for optimizing our outcomes. But when you find it, it's really a gem to hold on to. Today, we're featuring Ava Maria and their PDSA around loneliness. And they used a tool from IHI that stepped them through a PDSA and provided them with a platform to document their work. And Dr. Jurevich has already highlighted the importance of having that document to revert back to if we need it. So Andrea, if Billy was able to join you, let's have her walk through the PDSA that you all conducted in your facility.
Hi, Jean. Billy's not here, but I did go through with her and I typed it up. So if you would like, I can just go through it as well.
Sure, that would be just fine then. We'll let you take the next four slides.
Okay. So we did the, like what you mentioned, the PDSA style. So the questions and predictions that we went through was we used the modified UCLA loneliness scale to be utilized with the following questions. How often do you lack companionship? How often do you feel alone, not alone? How often do you feel left out? How often do you feel isolated from others? How often do you feel that there are people that you can talk to? Also a line left for, any resident comments, because sometimes they get a little chatty and they've been alone for quite a while. This has been a long haul for them as well. So with utilizing the loneliness scale, we anticipate that residents were going to have some degree of social isolation and loneliness, but it was really uncertain as to what level, so that was a challenge for us. Like we weren't sure what we were going to expect. If you want, I can turn my video on if you want. It feels a little weird. You guys don't know where to look. You do that. Does that work?
There you go.
Okay. So, so basically we got a group of us in management together to go over, formed our own little, I don't want to say committee, it wasn't a formal committee, but a gathering. We did QA nurse manager, social services, frontline care staff, social workers. We interviewed a random selection of 12 residents using the UCLA loneliness scale. The interviews were conducted during the day with willing participants, and as residents provided verbal consent prior to these meetings. The interviews occurred in the residents' rooms on 4/7, and privacy was upheld with the residents. So there wasn't any breach with anything like that when you're, going over one's feelings. Residents to be interviewed and assessed. So our plan for collecting the data for the loneliness and isolation, we utilized the modified UCLA loneliness scale. Our population, or our sample set of 84 residents, 12 were chosen for interviews to be and they were randomly selected. Residents who weren't able to communicate, we did leave them out, so it wasn't a true random selection, but for the most part it was. So our do was just residents were asked the following questions, which I had mentioned before. How often do you lack companionship? How often do you feel alone? Do you feel left out? How often do you feel isolated from others? How often do you feel that there are plenty of people you can talk to? Also a line left for residents questions, and also, some conversation with them too, as far as how they're feeling. So what we learned, and this was kind of what we had uncovered with some of this, with our analyzation and our summarization of this, is 67% of residents who were interviewed were positive for some degree of loneliness and lack of companionship, replying as sometimes and always to questions 1 and 2 on the scale. Only one resident responded sometimes when asked question number 5. So our prediction did align with our findings. What we found is kind of what we thought was going to happen, but it was at a lot higher rate than what we were anticipating. We didn't really think it was that bad. So our act, so what we were planning on doing is we were going to utilize management and direct care staff to provide some one-on-one visits with all the residents who participated in the study. The goal is 2 to 3 times a week for 15-20 minutes. And then we would repeat the scale again on 6/4. And as of right now, though, just recently we were able to open up for visitation. We're no longer in an outbreak status, which we were in an outbreak situation. So we have visitors coming in, and we're just ensuring that they are getting their visitors as well. So a little less, I think it's still good that we go down there and chat with them, but we know that it's a lot lighter here than it has been the past couple of months. So that's what I have for you guys.
Yeah, and Andrea, Dr. Jurevich here, just out of curiosity, do you have a sense as to, of those people that you surveyed and enrolled in this intervention, do they all have visitors, or is it a mixture of, Lone Rangers and?
I'm going to have, well, I forgot to ask Billy that before she had to go. I mean, she does admissions as well. And as you know, a lot of our nursing homes, it's a huge revolving door right now. But I'll have to look back because I do have a visitor's log that we do for screening as well. I want to say I'm pretty sure, about 95% sure that they are all getting visitors, but we'll reassess that. And if there's someone who isn't quite, getting the visits that they should be, that will intervene at that time too.
Yeah, I always reflect on the quality of the visits. Sometimes family members come in and it's all the old wounds get opened up again, and sometimes they're not always as uplifting as you would hope for. But that could be actually another element to a project like this, is to think about the quality of the visit, and work to higher quality visits in some cases. And quite honestly, sometimes it may involve education of family members, which, by the way, is one of our future grant proposals. We want to have an opportunity. So as we're doing this, with the ECHO program, we want to have family members join an ECHO program. So we would have a webinar and talk about things like how facial expressions with dementia can really make a big difference. If your eyebrows are raised, that's disarming. That's a happy look, or a surprised look, as opposed to the eyebrows being down and furrowed. And family members come in and say, look at you, you're all whatever, in a mess, and that just creates stress and bad energy. So just even trying to instruct family members on body language to help with the dementia patient could be a improvement in a quality encounter. So anyways, I just wanted to point that out. This is really outstanding. And Jean, I didn't mean to take over, but I just get excited about stuff like this, and just how wonderful it is. So Jean, yeah.
I think one important thing to consider with this, when I was visiting with Billy, she talked about the fact that they reopened, and so they hadn't had a chance to get to the re-interviews, or to do a lot of one-on-one visits yet. And now, of course, reopening plays into the happiness and the lack of loneliness, or the reduction of loneliness, if you will, for these residents. So when it comes to reevaluating, the results might not be completely attributable to the one-on-one visits that they're conducting. But what you've done by doing this PDSA and documenting it as well as you have, is you've laid the foundation for one-on-one visits again in the event that you'd have to revert back in the event of an outbreak. And you have a plan in place so that perhaps you would never reach that 67% loneliness factor, I'll call it, ever again, because that is quite high.
And what CMS has added into is having a designated compassionate care person for each resident, even during an outbreak. So after this, if this were to occur again, then it's just another intervention that we have. So it's never gonna look quite the same as this, because the regulation changes.
Mm-hmm. Very good.
Yeah, that's a good point. However, the data can persist. So if you do the loneliness scale, let's say quarterly, what you do is you show the percentage. So you got 67%, and then when you redo it after the intervention, let's say it's like 25%, right? So if it goes down, what you do on your graph is you put a little arrow and you say one-on-one, engagement with staff. And then you put another arrow down as to when you opened up, for visitation. So that's how you track what changes.
Right, just like the timeline for it. Timeline exactly. For the interventions. Right?
Yeah. So at a glance, you can see it, and somebody can interpret it and say, yeah, this all, and these are synergistic. I mean, it's just like with what we'll see in fall prevention. It's not going to be one intervention. It's going to be multiple cycles doing something to bring that number down. But now you've got a database, and I think that's the important thing. You've established this short form of the UCLA loneliness scale that you can use consistently now to measure your progress. So congratulations on that.
Yeah, I also note here that the tracker tool that is connected to the that Michelle has provided in the past, that's connected to the PIP. Really, you just enter in on that Excel file the number of, say, the number of residents that you assessed and the number that were depressed or not, and it automatically rolls over to that next sheet and shows you those graphs. And so, and then you can add those errors like Dr. Jurevich was mentioning it to say, this is what we did here and this is what we did here. But I was just letting you know, there's already a tool out there available, so you don't have to recreate the wheel.
Okay.
All right, well, let's open it up and see if anybody has questions or comments or feedback for Andrea. You can type it into chat or unmute your line and visit with us.
Yeah, Andrea, I'll say this is a great job. I love the progress that you guys have been able to see just in the short time. And as Dr. Jurevich mentioned earlier, sometimes there needs to be some family education. There was a book, and I'll look for it before next week, that we kept on hand in one of the facilities I worked on and handed it to all of the family members once their family was diagnosed with dementia or Alzheimer's. And it really just kind of explains the whole disease process to them and how to react to those residents moving forward. So
Right. We have a high percentage of residents who have dementia in our facility. I think we're at almost about 80%. So it's important for us too.
I'll look for that book before next week. I just can't remember the name of it.
Thanks, Kelly.
I was going to add that one of my colleagues who's in public health was looking at the whole question of just physical activity with dementia, and there's nothing in the evidence-based research about the impact of physical activity in dementia patients who have progressed to moderate to severe dementia, which is really unfortunate because it turns out that physical activity is one of the only things that really, and diet, that has an impact on chronic conditions. So a lot of these people with dementia, they have high blood pressure, they may have diabetes, and the question is their physical activity, what level is necessary to really improve their chronic conditions and perhaps delay the progression of their cognitive decline. So for those that track on the MDS, the functional, the activities of daily living, typically you're supposed to go down by 4 points each year with dementia. And so again, this would be another type of intervention that if you said, oh, we're going to have a certain activity program, you can actually track the MDS pattern to see if the rate of change, the rate of decline in their ADLs is slowed down, by your intervention. So that there's a lot of opportunity here.